The healthcare industry is ripe for disruption, but transforming the entire healthcare ecosystem starts with transforming the conversation around it. What challenges and inefficiencies are leading to poor patient outcomes? How will technological innovations influence the evolution of the healthcare ecosystem? What's at stake for patients, payers, providers, and technology partners within this ecosystem? Welcome to Getting After It, Transforming the Healthcare Ecosystem. Join Mike Simmons and Brett Zelkind as they navigate today's complex healthcare ecosystem by sharing expertise and insight on these issues and more in each episode.
Welcome to the podcast, Aditi, and it's really nice to meet you. We have done a little bit of reading about some of the things that you're interested in and that you've been working on, and I think I'm really excited to have a conversation with you today about telehealth and all the various sort of applications and ways that that's being leveraged and grown in today's healthcare environment. But maybe before we sort of dive into that work, it would be great to learn a little bit more about you and like where are you from? How did you get into medicine? What's driving you specifically into or in general into medicine and specifically in telehealth delivery modalities?
Absolutely. Well, welcome. I'm glad to be here. So I'm from Chicago. That's where I grew up, but I spent most of my time working in the emergency department in New York, Louisiana, and Philadelphia. I trained in emergency medicine and graduated residency in 2009. Like a lot of people, I got some burnout. And so in 2013, I changed my career a little bit. I joined a telemedicine startup. I joined Doctor on Demand at that time, and I worked with them for about 3 years. I was one of their first doctors. It was just starting. It was very new. And I got a lot of my just clinical background in telemedicine from that. And from there, I moved on to Thomas Jefferson University Hospital, where I ran the telemedicine program from 2016 to 2021. It was an administrative department, but I also ran the programs that were housed in the emergency department where I was faculty.
That's awesome.
Yeah. And then, so it's interesting when you talk, Aditi, about sort of like initial burnout and then the move to Doctor on Demand as a sort of startup in a startup space, right? So a relatively new business in a whole sort of new delivery system. Was that more refreshing, less stressful? Did that help sort of like re-energize you, or did that just sort of contribute? Like, how did that affect you?
It's a complicated answer. So I'll say that the reason that we get burnout, telemedicine doesn't necessarily fix. I went into it because I was looking to cut down on the ER shifts, and I liked the mission of what they were trying to do. I found it interesting. It was different. So I didn't work as many ER shifts anymore. I would work clinically in telemedicine. And so in the beginning, yes, it really did help because there's room, there was space to get a little bit better from part of the reason that you get burnout in the ER. But when telehealth also gets really busy and it feels overwhelming and there's nowhere to send patients, right? You're still having to take care of patients that may not be able to get the care they need because of insurance, of costs, whatever it is. It still leads to that same type of burnout. What I do think it helps, though, moving forward is having that hybrid and having a different way to work or having different places to work. And then for me personally, because I think and believe in telemedicine quite a bit for access and care. And so using a hybrid model for that and to make sure that clinicians, or it doesn't add to clinician burnout, really gives me another purpose more so than the ER. So in that way, it did help.
That's really, that's interesting. There's a couple of things that I guess that I think about when we talk about, if we think about like where you started with Doctor on Demand and we think about sort of like telehealth broadly, maybe like I think about that as like one major category or one modality of telehealth in sort of like a broader ecosystem. There you have like a direct to consumer, could be a B2B if it's like to a health plan, but it's sort of like ultimately geared towards the end customer being that patient directly needing the service. Can you share a little bit about kind of like how you think about the broader ecosystem in telehealth? A couple of things that come to mind, and when Mike and I were chatting about this ahead of time, we think about businesses like Rubicon, we think about like e-consultation, we think about like sort of like the pure play technology and infrastructure. How do you frame telehealth?
Yeah, that's a great question. I think you're right. Because of the pandemic, most people just think of telemedicine as direct to consumer. I think of it in two different buckets or two different definitions. It can be who the end users are, right? Because generally telemedicine just means you have two people on either end using technology to have a medical encounter. That's all it is really at base. And so the first type, you can categorize it by who's on each end. So it can be a clinician to the patient, like direct to consumer ones that we see. And even the B2B contracts, like you said, right? They're really still at the other end is the patient. And then the second is clinician to clinician. So like telestroke programs, you're probably referring to anything that has and connects two specialists together, one of which is the person who's taking the main care of that patient. And this is used everywhere. And actually, it's probably it's older than the direct to consumer model. It just wasn't obviously out in the public sphere. So people didn't realize that. And so, yes, that's more classic. And then the last one is really a subset of the clinician to clinician, but instead of a doctor, it's a doctor to maybe what we call a clinical telepresenter. That means it's a healthcare worker who is not a physician, who is doing the exam. So, for example, there's a neurologist, and at the other end, there is a tech or a neurology tech or nurse who is doing the exam on behalf of that neurologist. But again, it's a subset of provider to provider. But the other way I would characterize telehealth too is just by the modality you're using. So is it real-time video, real-time telephone? Because by definition, those have to be real-time. It's a little bit difficult to do them asynchronously. And then asynchronous telehealth, such as chat. So chat can be real-time technically, but it could also be asynchronous, or somebody comes back to it later to send a message. And so when you look at the entire broader scope, everything falls into one of those or two of those. And I think it's important to make sure that it's general because it expands how we think of telemedicine in general. It also makes us realize where the limits are and where we can actually expand it.
Yeah, that's super interesting. I wonder, with that kind of frame, what was the big differences between your experiences working for a telehealth startup versus working for running a telehealth department within a hospital? Like, what are you getting after the same types of problems, seeing the same types of patients for the same healthcare issues, or is it vastly different, or what's the difference between the experiences for physicians?
So when I moved to the hospital, it was a little bit different. Mainly because you have a more local area. Now, it was a huge academic hospital. We had a catchment area that had bigger parts of the state. We also covered and crossed over to Delaware and New Jersey. But in general, too, we were still looking at a different problem, right? We're trying to give better care to the people we have, and then also improve access also. And so really the programs were different in that now, instead of really just doing acute care, which obviously for my specialty is easy, or what we do, you're now trying to figure out and create programs for every specialty that was out there. And they're not all doing telemedicine the exact same way. So it was an interesting time because Jefferson, so Steve Klasko was CEO at the time, and his whole goal was to get as much telemedicine into Jefferson and into the health system as we could. And so almost every department was required to do some. Now, it wasn't dictated how they did it or what they did. They could try to determine for themselves what they were doing. So anyway, as you can imagine, everyone did things a little bit differently, right? The neurology, they did telestroke, surgery did some post-operative care, anesthesiology might do preoperative care, similar things in ENT would do post-operative care. The emergency department, we did a direct-to-consumer model, most easily described because we were seeing acute care patients in the community. And then we also created a program in the ER where any patient who came in, they were actually seen by an ER doctor remotely. So their orders could be put in, and then they were seen on site after their orders had been started, seeing their labs once in the ER and then discharged from there. So it was a lot more interesting in the amounts of things you could try out. Some of them failed. I will say that there were programs that we tried that didn't work that well, but we were able to use and try it out in a lot of different specialties. So I think that's just the beauty and the difference of having a health system versus a direct-to-consumer model. So obviously, at Doctor on Demand, you can get really good at the one thing you're doing. In a hospital system, you could try a lot of different things and see what works. And then most importantly, do the research behind it to figure out what works and what doesn't.
When I think about when I started my career, Aditi, at the health plan, it was really, we thought about all healthcare as local. Sort of so much about the focus of our health plan was about our understanding of our members in our community and the communities that we serve. How do you think about sort of the role of telehealth, sort of like either expanding on that notion or running in conflict with that concept?
It's a really good question. So I'll just say that historically, right, telemedicine was set up in places where people really couldn't get care. It was like NASA, right, or military Navy ships where you really had nowhere to get the information you needed. So it really was used, like you said, for all of these distance care. But I actually agree with you that I do think that healthcare is local. And we're seeing that now come out in what telehealth is actually going toward. And I'll tell you why. So initially, right, it was to increase access. We needed to get care to rural areas. We used it for IHS, the VA, all of these places where people may be far away from the resources that they needed. And so telehealth is a great solution for that. But it ends up that most people and most patients really actually want a local doctor. So when I started at Jefferson, one of the survey questions we asked was, would you have, was it important to you that this was a Jefferson doctor or was it not? And initially they said it wasn't, but eventually, that answer started to change. I'm co-writing a book with someone about telehealth. And part of the research questions and research we found is that since the pandemic, now that it's expanded even further than this one question we asked at Jefferson in 2017, patients are finding they like it better when they can see their own doctor on telemedicine versus a doctor they don't know. I suspect that initially patients had no choice in the matter. So they like the convenience of telehealth, so they didn't care who the doctor was. But now they know more about it. They actually want someone who's local, maybe it's their own doctor, or at the very least is in the health system that can refer them into their local doctor, the local specialist, because that's just easier for them to understand. It's just more comfortable, right? So I do think it's going to become local. The more it expands and the more we implement it into all of our healthcare systems.
Yeah, I mean, that's really interesting. Like when you think about, I always remember this quote that I was listening to a talk from the CEO of Teladoc, Jason, quite a few years ago. And he said something that I'll never forget, which was, you can't do a pap smear on an iPhone. So like there are limitations to what you can get done with telehealth for sure. But I think when you think about like the way that healthcare and connectivity are becoming so ubiquitous, or connectivity in healthcare is becoming so ubiquitous, like there are things that are becoming part of the telehealth ecosystem that will be part of even those exams that have to be done in person, right? So like, what are the frontiers? Like we have this model, right? That you can get a consultation, you can pretty conveniently pick up your iPhone and get connected with a physician. If you have, that option through your health plan or whatever. But what are the like edges of where telehealth is going that's maybe not so obvious, like in those settings that are even where you're like in person, that you're also sort of able to take advantage of the telehealth ecosystem that's emerging?
So this is why I think it's really important to set the stage and say that the definition of telehealth is broad, mainly because we can almost add on all sorts of things. So, to answer your question, just at the base, you look at what's going on in RPM, all of those devices or add-ons to phones, let's say to even for physical exams like stethoscopes or otoscopes, they're all adding to the exam for telehealth itself. And then the RPM is just giving better data on what's going on when patients are between medical visits, right? And so we can use that data to maybe give them better care or make sure that a chronic disease doesn't get worse, anything that you can think of, right? We're already seeing that, especially in research, and people are starting to use it. And what's interesting is that if you look at some of the tech that's out there and the way that people are thinking it'll happen in the future, there's some things that seem actually fantastical almost. For example, people are saying that, from far away with robotic surgery, you might be at a distance, be able to do surgery with the robotics. I think we're far away from that. I don't think anybody would trust that. I don't know any surgeon who would trust doing it without somebody in the room at that time. But the reality is, there's a lot of there's a lot of opportunity for that. Now, I don't think that's ever going to happen, not in our lifetime, because I do think there is some human aspect, and a lot of tech can grow and people aren't necessarily willing to take it in or implement it because it's a little bit scary. But I do see the end of it. But in general, for now, what I'll say is that surgeries we'll still need hospitals for surgery. We're still going to need them for emergencies. We are going to need them maybe for some preventive screening, things that we can't do over video. Now, it may not be that we need a hospital for it, right? To give out vaccines or even to do pap smears. Maybe there'll be an intermediate place to do some of these things that we haven't even thought of yet. But we can see with some of the add-ons and these devices that we have and that are coming out, we'll probably be able to do that sooner than later.
So on that front, again, just sort of like if I sort of reflect back on some of the conversation that Mike and I were having in advance of this conversation, I was thinking back to like when my daughter was born, right? And, a dozen years ago. And at that time, I would gladly spend $1,000 on a stroller. If somebody said to me, buy a stethoscope for $200, I would, jump to do that, and any other devices, right, that were being sold at, the children's store, the pediatric, or whatever the pediatrician told me to do, I would gladly have done. Do you think like sort of the investment in sort of like these dedicated connected devices are really sort of like niche, high cost edge cases, or do you think of them as sort of like rapidly expanding to the masses?
I think that depends, right? I think we hit it on the head. In some way, it's going to be cost prohibitive for certain populations as a niche product. But what I think we're seeing now, because, what initially a lot of devices they're expensive and a lot of people didn't really need them. They were just using them at home for maybe a short period of time, or they needed it for a certain disease. But I think what we're seeing now is that there's enough out there that a lot of the companies or RPM companies are using it for certain chronic diseases. We're now able to actually bill for it. So that also helps to the patient and the clinician. And certain companies also, you can send the devices back in the case that it's not something you need all the time. And they can obviously clean them and then reuse them so that somebody else can do that. So you're really renting it out. I think that makes much more sense than somebody, for example, when you had your daughter, there would probably be a few years you might need an otoscope that would have helped. But after a certain age, you don't really need that. So what are you going to do with that the rest of your life, right? So in those cases, it would make sense to pass it on to somebody else who could then use it. And so we're seeing that now. And the model is that in most of the RPM companies that are out there, especially the ones that have apps themselves and are device agnostic. Most have contracts so that they can use this. So it's going to be more useful to more people. And if you look at the research that's out there and the billing and the reimbursement that I'm talking about, it is for certain groups of patients, which are really useful, really especially those who have chronic diseases. And with that, we'll probably be able to make sure there's less of a disparity in who can use them and who gets access to them.
So one of the things that I think a lot about is there's sort of a cost curve that we're trying to break in kind of American healthcare, where it's getting more expensive and the value that we're getting back for all the expense is sort of questionable. There's at least a lot of shade being thrown on why is healthcare in America so expensive? Does telehealth add costs at the end of the day, take it out? Is the jury still out on that? What are you seeing in what are you seeing from a cost perspective? Because we know there's some access things that it's really helping for sure. You can think about those use cases and say definitely helping that AAA. When it comes to cost, what's sort of the research saying now about breaking the cost curve through telehealth?
Yeah, it's a good question. And everybody wants to know, I'll say initially trying to implement a telemedicine solution and buying a product that was expensive, essentially for most people. And so I think that ended up being, and they weren't getting a lot back for it. So it was really an investment in trying to see if it worked. But I think it's come to the point that we are seeing so. So if you look at first, we just take huge programs. So if you look at the VA, for example, they have found it's cost effective for travel times, savings, because they pay for all of that. right, for their patients who are coming through. And so they have seen that it does save them money when they're using telemedicine. It also makes sure that patients are seen a little bit sooner so that they assumedly don't get sick later. And then indirectly, it saves costs on lost productivity. This is true for IHS too. For IHS, obviously, there's places that are very remote. And so they would have to fly a doctor out to them, especially specialists. With telemedicine, they've had to do that a lot less, and that has saved a ton of money as well. They have probably the most amount of data if you look at it. And I think that helps that they have one budget, so you can really look at it directly. But we can assume that's probably true for other places. We may just not have the data at such a high level to tell. But again, they also use one product, so they can clearly scale that a little bit easier. The cost is less. If you look at the individual, sorry.
Oh, sorry. I was just going to ask, if you don't mind, I was going to ask a question on those. Yeah. The Indian Health Services, the VA, they're relatively small pieces of the sort of total U.S. healthcare spend. Mm-hmm. And I think, and I could be sort of incorrect on this assumption, maybe correct me if I'm wrong, they are populations with needs that are different than the general population at whole. In other words, like, are there more medically complex? I think in the IHS system, it is proven to be the case. A lot more needs with regard to like mental health, alcoholism, and other chronic conditions. So, like, can we extrapolate that to the working population, the Medicaid population as a whole?
Well, based on the data, so the research actually and what they were using telehealth for wasn't for all of those things. It was for substance abuse or substance use disorder, hypertension, and diabetes. And hypertension and diabetes actually can be looked at in the entire population. Also, substance abuse disorder. We have a lot of that outside in the population as well. You're right, it can be medically complex, which makes it more expensive. But the cost effectiveness, interestingly, was really on the travel portion. This ended up being where they saved the most amount of money because they were actually able to access care. In fact, apparently the IHS saved enough money or saved so much money, they were actually able to take some of those funds and try to make and create better programs for those diseases, which is huge. But yes, if you look at the general population, what I think is difficult, so if you look at the cost effectiveness, there are small studies showing that it is cost effective in the same ways. What I think is difficult is that a lot of the data is not going to be as huge a data set. But if actually you want one, telestroke, which is not specific, but again, telestroke is also rural areas. There might be FQHCs involved, but that actually has shown to be cost effective as well and to improve mortality, morbidity. So in that way, there's another place to do it. But again, it's very sick population.
Yeah, no, I mean, I think I'm super excited about what telehealth can grow into in our healthcare system. And I think like it is without question proven to drive tremendous amounts of satisfaction. And there's lots of great data points where, especially for medically complex cases, there's a tremendous amount of value that's delivered. I think, Mike, to the point that you were making, right? Like in supporting the triple aim or the quadruple aim or whatever sort of like terminology you want to use to describe that. And then the questions really become like, where today is there still a lot of opportunity for innovation to sort of yield the benefits that we're looking for more broadly than just sort of those conditions?
Well, and generally, not every population is using telemedicine at the same rates. And we can break it down in different ways. So, for example, women use it more than men. A lot of that has to do with just the way society works, right? They generally are more part of the caregiving community. They're generally in charge of taking care of the children's health. And so they tend to use it more. But interestingly, they also have found that they use it for themselves more. And so they're getting more healthcare. But then men are not necessarily using it as much. And there's a big gap in men's health. Also, if we look at racial and ethnic lines, Hispanic and Black populations were using it less. But, if you look at some of the studies, when they did use it, they actually had better outcomes compared to other people. And so that's really places you really want to make sure that there aren't these gaps of access. And we can break it down in so many different ways. You go to rural areas, who has connectivity, who doesn't, costs, all of these things have to be broken down. And so you want to look and make sure that access, there's still those opportunities to fill those gaps. We are seeing that there are companies that are trying to fix these particular problems to come together to really improve the access to those areas. And then if you look at like convenience too, so going back to how convenient it is, it's very convenient for patients, assuming they have connectivity and they know about it. but it's actually not necessarily convenient for clinicians. It's less convenient for them. So there is the opportunity to make it easier for them to do it, because the realization is that they need to do it, they want to do it, but if it's not easy, it's just going to be hard to be able to overcome it. And then, of course, we just need to make sure the reimbursement stays, right? We all know and have been talking about the waivers going away, even though the Omni bill covers a lot of services that will continue. A lot of things are up in the air. Each state is going to be able to decide. And so there's going to be, again, a discrepancy on what people can get and what services they can probably access based on the state. And that honestly just takes a lot of advocacy and lobbying. So if it's important, I really say that either go through your specialty organization, your state representative, whoever it is, that can help with that.
What are the things that make it inconvenient for a clinician? I know I haven't really thought through that set of problems that much. What's been your experience?
So if it doesn't really fit in the workflow easily, it can just be a bit of a pain. So it just has to be easy to schedule. It has to be able to fit in wherever a clinician needs to use it. It has to be easy to use. It shouldn't be hard to get into the medical record and then have to get into the telehealth record and then go back and forth and not be able to talk to each other. And really, we just need to be able to get the correct data into it so that we have access into looking at it while having a telehealth encounter. This is easier depending on what you're using. Let's say you're a big health system and you're using the same platform for your EHR as well as your visit. But if that's not the case, it just ends up as an added burden. And I also think that's just in general, and this is not specific to telehealth, but the health system in general, there's still a lot of administrative and charting burden on clinicians. And so this just adds to it. And if they're not being reimbursed, which a lot of times they weren't for the amount of time they were doing, it just ends up being worse for them. And I think there's still a resistance to feeling, how do we do this safely? How do we make sure that we're delivering the right amount of care? And this is why it's really important for people to get trained in it, which I do quite a bit of, because I understand that, it's the more you do it, the more you train in it, the more comfortable you are in it, the better and easier it is actually.
I've got kind of two other things that I'm really curious about. Maybe I'll just start with, some of the stuff that I've read that you've published talks a little bit about like the workforce, the lack of enough people in the workforce to actually support the healthcare demand in our country. So and I guess that's probably true. Like you can probably get a little bit like incremental productivity, maybe if you like layering in telehealth on top of the regular practice, but there's still a max that you're going to a maximum incremental positive effect from that layering. But if you, I wonder what is going to be, what's the frontier looking like right now for like large language model AI-based chat engines? Like we're seeing a lot of, every day we see another story about ChatGPT, right? Like, is there a clinical application of something built on a similar language model? And have we seen anything like that so far? Are people sort of going in that direction and working on it? Or do we think that that's an area that's maybe not, for some reason, not likely to yield a benefit in the workforce area?
That's a really good question. And I'll take it in two separate parts, because the first thing I'll say first is, yes, AI has a huge opportunity. So I'll use emergency medicine as an example. What would be great is that if you could triage patients who may not be sure, is the ER right for me, or can I wait the urgent care? At the moment, most people will speak to a doctor on video to get that information, but it doesn't have to be that way. There could be questionnaires or AI algorithms that could do that, right? And give them at least an answer that's yes or no. There's still going to be that interim where it's going to be checked clinically, right? We're not going to take risks with people who might be missing something, but some of them are really good. They're not necessarily going to miss something. If there's even one flag, they'll have them speak to someone or get some of that follow-up. And so the better that gets, that's one use case, for example, that could make it a little bit easier. It makes it easier on the patients too. I mean, they don't want to wait 6 hours in an ER if they don't have to. I mean, nobody wants that. What I think is happening though, on the second question about the clinical workforce, because we're not there yet, because we're still testing these out, because nobody is quite sure that it's at a place that we can trust it completely. We're still testing it. Like I said, we're still doing research. It's ending up that to get there, we're doing extra work to get there. So there is an increased burden on that clinical workforce to try to get there, to figure that out. And so it's going to take a little bit more time of probably clinicians doing extra work before we get to that point. But I'm a bit afraid that we don't have that workforce even to get there at the moment, right? Yeah. We're losing a lot of physicians, clinicians. I don't practice. I haven't practiced since 2021, for example. But then it also occurs to me that people who may have retired or may have gone part-time or, had a lot of burnout and they used to practice, they're probably the perfect people to maybe bridge that. They can test it out. Maybe they go back and do it part-time to test that out. Yeah. So maybe that's a solution. It's just a different way to do that work. And it's allowing people to use their expertise without burning them out more.
Yeah. So I think what you're highlighting, let me make sure I understand that, like the extra work that you're talking about, I guess that's sort of the other side of the machine learning is like humans are teaching the machine for a while. And we don't talk about that nearly as often as we talk about, machine learning. I don't know, there needs to be a term for the other side of that coin, which is like human teaching, right? Is that what you're talking about? That's adding additional work for the clinicians?
Yes, partly, because even if there was an AI algorithm, and I believe in it, I would still check it and just be like, okay, until I use it enough times. And I was like, okay, I can check it. I feel like this makes sense. Yeah. And so it's just, something that's supposed to be replacing some of the work we're going to do. Until we trust it or really understand it, we're not gonna do it. And I think it's just, the way we're trained, there's a lot of onus and responsibility put on clinicians, especially physicians. They're the end of the line. If something goes wrong, that's who everybody blames. And so, and also we take it really to heart when something bad happens. We weren't going to risk anybody's lives. We're not going to do it. And so I think that's where it comes, that burden. It's because we're not there with the tech, and also we put that burden on ourselves, and it's just going to take some time to move through that.
Yeah, I mean, I think it also really speaks to something else that I think is super important in this conversation around AI, which is like the AI companies that are developing this need to be able to provide a logic trail, right? That shows, how did you arrive? How did the brain that's artificially generating an answer, how did it arrive at that conclusion? And be able to go back and check those logical steps is, I think, a really, really important part of like making AI responsibly able to get to more, help us with more solutions. I think there's no more compelling case for that than healthcare solutions, I think.
That's true. And you make up a good point, because when I say AI, I realize most of what I'm describing that I've seen being used in healthcare are really algorithms. So you can see it. It's not really a pure AI machine learning. It's really looking at an algorithm.
Yeah. Yeah. And as we get more towards, that's a journey, right? And that's one stage on the journey towards real AI is an algorithm that can generate a good sort of factorial answer. The next step is like, okay, it's just instant. There's an intuition that's working, but those mechanics still need to be auditable. And I think that's a really important piece of, for sure in healthcare applications, you've got to be able to get there.
I agree, absolutely.
So the other thing that I was thinking about is in sort of like looking at all these different frontiers. What are you seeing, if anything, internationally that's like that we might be able to learn from about the application of, I guess maybe this question is maybe broader than just telehealth, but in general, like solutions that are being adopted or proven in other markets, whether it's other sort of Western markets or even like innovations that come out of, having to provide healthcare in Africa or some, remote parts of Asia. are there like interesting things that you're tracking in the research and stuff that you're doing that has like that we could learn from maybe in American healthcare that actually is inspired by international use cases and concepts?
Yeah, absolutely. And some of it, I can't tell if they learned from us first and decided not to make the mistakes we did. It may be that, and then we can learn from them actually. Yeah, right. Yeah. But there's a lot of interesting things too. One of I'll say in general too, everybody in different markets, they understand the problems of their country or region well, and they realize that maybe they have to be a little creative with what they're going to do. So I think of, there's a woman I know, she started a company in Bangladesh, for example. And at the time they had like 4 labs. People had a really hard time accessing care. So she actually set up a hybrid model to start with. It was telehealth, but also had some on-site clinics. And so they could figure out how to solve both those problems, both the access portion, but then they had a place to come so people get labs and workups, et cetera, whatever else they needed. Because she told me that she took best practice from around the world, so they didn't have to repeat it. And even actually with a very minimal amount of funding, well, what we would consider minimal amount of funding, at least in like 1 million plus patients. I mean, they really are seeing quite a few patients. And I found that interesting because we think that we have to have some huge amount of investment or time, but not really. It can make a huge difference just being thoughtful about the process. Another thing I find really interesting about the European market in general is that the companies here, it's much harder actually to go from start to finish to really be successful. So if you look at Germany, for example, they're very strict on who gets into their DIGA or their medical device formulary. Once you get in there, doctors can prescribe them to everybody, but you really have to uphold clinical evidence and outcomes. And if you don't, they'll take you out of it. So even though it's really hard, the companies that do succeed, they actually tend to do really well. And so there's quite a few of them that have come to the US and do really well because by the time that they actually succeed in Europe, they've been put through the ringer a bit. And it's really interesting to see how much evidence they have and how many patients they've seen. We have a different model, right? We're really open and we let people can try a lot of things, but then we also sometimes see things that don't really have real usability. And so, they maybe fail. So it's just an opposite way to think about it. But yeah, there's a lot of interesting things that happen everywhere. But I will say that overall, everybody is really trying to solve the problem of how do we access care? How do we make sure that we're getting as many people care with a dwindling workforce because everyone's having the same problem with burnout. So a lot of the stories are similar, but not all the solutions are exactly the same.
Maybe there's like 2 things, Aditi, that I wanted to go back to based on what you were saying earlier. And I'll bring it back domestically here now into the conversation. One thing that you talked about was sort of like the additional work put on the clinician or and the strain on not having the integration between the scheduling or the EMR and the clinical node access. So in that vein, business models like Teledocs and Talkspace versus sort of like a more pure play technology platform, right? An EMR or an Amwell, let's say, or EHR. Is there room for both, do you see, in the marketplace? Do you think that one is going to ultimately become more dominant than the other?
I think we're too far gone, right? In some ways, because EHRs aren't really telemedicine platforms. I know Epic does telemedicine, but they're not a telemedicine platform. A lot of telemedicine platforms will do it much more easily than Epic does, honestly. You could do it, but it's clunky, to be perfectly honest. It's not meant to do that, right? It was doing it because it could. It's tough because it almost feels like we've come to a place that EHRs are already a part of various health systems and hospitals. And then putting in a telemedicine platform is separate to that, just the way that the market developed and how it's worked. I know there's a lot of talk about how do you integrate it, but I think what is probably most important to understand, because I think that gets very complicated and I don't think we're going to solve it here today, no matter what or how many things go into the app orchard. But what I think is most important is that when clinicians are able, trying to do their work, it's not like 10 things open, let's say. If it's just one, and let's say you're still, okay, I'll give an example. It's the way we used to do it. We would have our visits in our telemedicine platform, which is white labeled as a Teledoc platform. but we would actually document an epic, but we wouldn't go back and forth. It was really just, we would document an epic, and we just really needed that for the video component. Mm-hmm. It's a little clunky because it doesn't come out itself, but it doesn't make my job that much harder. But this is what I mean when clinicians are just used to working around a lot of different things. Things aren't built for that. I don't know how to put those two together because you really need a lot of cooperation in the market for that to happen. And I just don't see that happening, not in the way that we need it. Not to be a pessimist, but a little bit. It's like practical too. I don't know how much is practical and how much is pessimistic.
Do you think, is there a potential catalyst that would change that? Right. So I think about the public health emergency, right, was a catalyst for telemedicine in sort of, I think I'm probably on more than two fronts, but one was sort of like the fear of being in public, right? So not wanting to go to the doctor's office, so telemedicine was great access. And then the second, which you spoke of before, which was reimbursement, right? That was, and it probably, we can sort of think about which was more important in that, but reimbursement drives a lot of behavior. Is there a potential catalyst that would change or affect the challenges that you were speaking about, which was sort of like not having a sort of strong integration or efficiency in applications?
The only thing I can see potentially happening is if there was a solution that was cheaper and easier to install than all the things that we already have that really just took over the market. I think that's the problem, right? It's a huge investment to get an EHR, to implement it. I mean, it's millions, billions sometimes, right? To get that into the system. And so you're not going to easily change it if it works. And then if it's widespread, then people do that. And so if there was an easier way to do it, and so something that had ease of integrating other technology apps, whatever may come, already had a video telemedicine, and was set up for charting and reimbursement, right? That's what EHLs were meant to do, was to be able to get best reimbursement and billing. If there was something that came out that really was much more feasible for everyone to do, then I think that could change the market. I can't imagine that there would be, like, a pandemic wouldn't do that, right? That wouldn't help. In fact, nobody would do anything in an emergent fashion. It would really have to be something that was so much better and so much easier that everybody just bought it.
Got it. And then the last question that I had that I've been thinking about a lot is, and going back to what you mentioned at the very beginning, which was patients, individuals, right, were initially attracted to telemedicine in part because of the convenience and the experience. Do you think that potentially opens the door and leaves room for businesses that we hadn't historically thought about as being healthcare oriented, right? Potentially becoming more dominant players, right? So, Apple, Amazon, Best Buy, Walmart, right? Do we think there's going to be a winner? Is there enough room for everybody to win? And I would sort of contrast that with, a company like Beacon or Magellan, who didn't act on telemedicine early on when they were sort of dominant in their domain in sort of like the behavioral health networks.
Right. So as far as these, big tech companies getting into healthcare, I mean, I think they're going to want someone to be the winner, right? They're all competing with each other, depending on what's going on. Well, depending on what they're doing and depending on what domain. What I think they have a better ability to do is to try new things, accrue new knowledge. And obviously Google has a really good way to use AI, as does Meta. All of them are doing things with this technology. They understand it better than we do in healthcare, but they don't actually have any clinical background. So I think that they're probably going to find out it's much more complicated. They probably already did, right? With all of the ones that Google tried and then pulled out of, and Amazon as well. They're finding that it's more difficult to do. But I do think that there is going to be an opportunity to understand better what the market is going to want, what consumers want, what patients want. And I see that's where they're going to be able to give the most back, because with the data they have, they'll say, all right, this is what we need to start providing. And who knows, maybe they are going to provide it better than hospital systems, and they will take some of that burden off of it. As long as they do it in a way that everybody can access it, I have no problem with that, because I do think that they have a better distribution. They have a better idea of like what is going on out there. But I think and that's where I think people are very wary of it, is, are we going to make sure that everybody's still getting the right amount of care? I don't have a great answer. I'm actually I'm more interested to see what's going to happen, because I don't think that you can predict how tech moves forward. I mean, if we had thought about 20 years ago, I forgot my first email account, that this is where we would be today. I couldn't have predicted that, right? And so I think that's why it's hard to determine what is going to happen in the healthcare space with big tech getting into it. But I'm hoping we get some better data out of it.
Yeah, at the very least. I think what I think is really interesting, because it's at the intersection of local and with sort of big tech capabilities emerging from these organizations, like the big box stores, like the Best Buys, Walmarts, Targets, that are in all their in each in their own way advanced, taking big steps into the healthcare market. And I think that's a really interesting frontier. Not big tech alone, but like they have real tech capabilities, and they're getting better and stronger, and lots of funding for that internally. And then they have the local setup where there's millions and millions of people going through their doors every day. And I think that's a really, really interesting intersection to watch. Have you done any research or work with those types of organizations, or seen interesting things in the telehealth space coming out of the kind of the big box stores versus big tech?
Not particularly. Years ago, I remember they're setting up kiosks and CVS, but it was a little bit too early for that. And that was the only time that I was involved in anything then. But not recently. I just follow it in the news. But I do, I think what the box stores, like you're saying, that have physical spaces, again, they're going to be able to do the hybrid model better, right? They're going to be able to do, maybe they're going to be the interim place that we were discussing earlier that can do some of these vaccines or things that are, actually CVS and things can already do that. Target can already do that. So maybe those are going to be the places where patients can go for that, so they don't have to go to something that's more expensive to them in the healthcare system. And I can see that happening. And that makes much more sense to me when they have a physical space.
Yeah, actually, I got my last booster shot at a Target just a couple of months ago. So that's a perfect use case. Cool. Well, this has been a really interesting conversation. Thanks for spending some time with us. I think maybe in closing, I kind of always wonder, does telehealth as a term stick around, or does it just become assimilated in healthcare? Like, we don't talk about like e-banking really anymore. It's like, that's just the relationship that I have with my bank. At what point, what needs to happen, or like, how do we get to a place where a digitally enabled, kind of full care environment is like, it's just what healthcare is to us, versus like this whole other category that we're tracking and looking at differently?
Hopefully sooner than later. I agree with you. It's not going to stay like that forever.
Yeah.
I think when the entire population, when somebody says they went to see their doctor, does not assume that you go to the clinic. When we get to the point that people realize that you might have seen them online, or they're like, you might be out or at somebody's house, and they're like, I'm seeing my doctor. When we get to the point that that's normal, then we'll know that we've really come there. But I will say, it just to make the point that the reason that it's okay at the moment to separate it is for that research component, for that information, that data component, to say, okay, this is safe. We should all feel comfortable using it. This is how we can be safe using it. And so for now, yeah, we still have a little bit of time to do that before we can get there.
Awesome.
Thank you so much for spending time. I know we jumped like right into this with the questions, Aditi, but really appreciate all of what you've shared with us and your experience that you've had and the time that you've invested in studying and mastering the space.
Thank you so much for having me.
You've just listened to another episode of Getting After It. If you enjoyed today's show, don't forget to like and share to spread the word. Subscribe to catch future episodes and visit andros.co/podcast for more. Check back next week for more information on what's happening in healthcare and how we can create a better healthcare ecosystem that provides better care for all.